I know a piece that is close to the hearts of many people in the room here, people living with rare diseases, family members of people living with rare diseases. It's the struggle, the daily struggle that people have, putting all the pieces together. You know, making sure that you've got the right appointments. Are you doing the right things? Have you had the right tests? Have you been assessed? Are you getting the right treatments and stuff like that? And that, I guess, is what Anne Lawler would speak to as the back of the ranch kind of stuff. This is real life. This is the fact that I'm struggling on a daily basis to keep the show on the road. Maybe I need an assessment for a child for education purposes. It's all of those pieces. We're fortunate, unfortunately, not to have in the country, but we do have online, is Raquel Castro. She's Social Policy and Initiatives Director at RDD. And I guess this is Raquel's bread and butter, seeing what needs to be done across Europe to make life easier for people. You know, what does holistic care look like? Raquel, I guess her day job. Hi, Raquel. Her day job is around integrated health and social care and social policy, and looking at disability, employment and non-discrimination rights. I know that she will speak to many people in the room, she will resonate with many people in the room, and I'm really looking forward to hearing what Raquel has to say. Thank you very much.
To come and to be in the same room. Thank you for the invitation. I'm very honored to speak among such distinguished speakers and to join you for this conference. So as Vicky was saying, I represent RDD. I believe most of you will know who we are, and I know that our president was speaking in the morning as well. So we do work across borders and diseases to improve the lives of people with a rare disease. And we have over 1,000 members, 15 in Ireland, including, of course, Rare Diseases Ireland. And we have the vision. I'm very happy at the same time as feeling the weight of speaking after your health minister. At the same time, I'm very happy to speak after and to hear about the ambition in Ireland and even his call for us all to be ambitious. Because our vision at RDD is quite ambitious, and we really want everyone with a rare disease to have better lives, not just longer lives, and to achieve their full potential. And this is where I'm going to focus more. We're so ambitious that we have a position on holistic care, which is quite ambitious and still far. We did it until we thought by 2030 we want to have all these things, but they might not all be there. We went as high as we could. We aimed as high as we could. And within that position of holistic care, there is one essential pillar on integrating care. So really, as Vicky was saying, on bringing all those pieces together. And as our president mentioned this morning, Avril Daly, we also are calling for the EU action plan with the support also from Ireland. And in that, we also, of course, include this priority of making sure that fully daily life issues and living to our fullest potential is included also in that EU action plan. So I was very happy to hear your minister speak now and to really, and also this morning to hear more about your ambition towards your future, your upcoming plan. And so to know that you want to ensure that people with rare disease and families have the right care at the right time, at the right place, is really reassuring, and I'm very happy to give my small contribution to that. So I do have some slides which I will try to not kill the wall by PowerPoint. So hopefully you will see them now in full screen. So I'm just going to speak a little bit about why integrated care, but there's so much to say. And Vicky was just saying what does holistic care mean? And I think it means something potentially different for everyone. So potentially something different for every 1 in 5 that your minister was just saying, that probably living with a rare disease in a household with a rare disease, right? Because when we're talking about holistic care, we're talking way beyond the person themselves and talking about the whole family or the closest ones that live with that person or close to that person. So it's a very broad area, and of course it's quite challenging, and it does mean something different for everyone, or at least no one's life is equal to another one's, regardless of which disease, and whether they live with the same disease, and whether they live in the same area of Ireland or not. A reminder is that we conducted an European survey a few years ago around these issues of daily life, and I know many of you in the room know this, so I won't actually go through it. It's overwhelming just looking at the slide. But rare diseases do have an impact across really different areas. They affect our functioning. People have challenges with daily tasks, relations, communication. It's not the same number of people for everything, but it's a very high number of respondents to this survey that had difficulties with different areas of daily life. And this goes beyond. Some of these might be addressed by treatments or healthcare, and some are not. And here I would like to focus a little bit more. So in the same survey, we actually saw that 65% of the respondents, which is not surprising to any of us, had to visit different health, social, and local services in short periods of time. So we all know that. The problem is, what do we do about it? But we'll get to my small contribution to that. And we also heard from the respondents, so they were either people with a rare disease or a family member, that 67% of them felt the services communicated badly with each other. 7 in 10 also didn't feel well informed about their rights, which obviously makes it difficult to access them. And 7 in 10 found that organizing care was time consuming, which again is not a surprise to any of us, and hard to manage for 6 in 10. So as Vicky was saying, all the things we have to manage daily. And the consequence of that, and there were many in the survey, but obviously I know you know a lot of them, so I'm just going to highlight some of the consequences, is the time spent on care or managing the things that come with living with a rare disease more directly is significant. And considering we all have 24 hours a day, if you're spending more than 2 hours per day just to manage things around your care and your condition, that's quite significant. And as a consequence of that and many things that we live with, 7 in 10 people with a rare disease or family members have to reduce or stop professional activity. And this is huge. So when we think about what is the importance of professional activity in our lives in terms of obviously personal development, satisfaction, but our economy, our social participation, etc. This is huge. And we also compared ourselves in that survey. We used a question that was used in a general population survey in Europe, and so we could compare ourselves in terms of mental health to more general population. And we see that people with rare disease and family members reported feeling depressed 3 times more than the general population. So these all and many other things we saw in this survey come all from the many aspects of living with a rare disease, and the fact that our care pathways are still, and our care is still not there yet at what we would be our ambition. And actually, a few years ago, we already had the fortune to be involved in the drafting of European recommendations back when there was an expert group for rare diseases that was coordinated by the European Commission. And there were some recommendations that initially, well, actually, they were still called like that. They were focused on incorporating rare disease into social services and policies. So that was the point of departure. And they ended up being recommendations very much about multidisciplinary, holistic, person-centered care, and not so much about social services as such, because we realized that we were in a sort of a ping pong between health and social services when it regards to things that are daily life generally and not necessarily directly healthcare. And it was this ping pong led us to think integrated care has a huge role, amongst other things, to really make us have better lives and live our full lives as we want. Now, how to achieve it? That's the $1,000,000 question. And I don't have the answers. but but there are some things that at least we've been over the years discussing with experts and through projects we've been in discussing with different people from different countries and taking good practices. We've identified a few things that we think are essential. So one is having integrated health and social care pathways. Very easy, not ambitious at all. And of course, making them person-centered. And that's we talk a lot about person-centered, and even within patient organizations. And it's quite challenging because person-centered means individual. And as I was saying before, people don't want the same things. People don't live the same way. It doesn't matter which condition, etc. So of course, it's a challenge to make it really person-centered. And we also need it to be lifelong. We know it cannot stop and it cannot have the huge hurdles between pediatric care and adult care, for example, as we still have. And it needs not to be just about care, because sometimes care is essential, obviously, but sometimes it's also it's not everything. There are some things that are not really care, they're just support, or they're just things we want to do and that we want to be able to do, but it's not necessarily that someone is caring for us. And one of the things we're very keen on at RDD is case management, and there's a reason, and I will tell you a bit more why. I did also speak at a meeting in Ireland a few years ago about the same project, but we didn't have the results yet back then. So if some of you were there, you'll have something new. And training of professionals, of course, is essential. And we talk a lot about training. We usually talk about training in healthcare, but training of professionals outside of healthcare, education, social, is as essential. And then lastly, I mentioned disability assessment because it's something we're working a lot on, or trying to, because we've realized that these procedures to actually access disability rights and support that is available for persons with disabilities, and many of us live with disabilities, that these processes are essential to access certain rights, and that many times the information that comes from the medical side is quite essential to these processes. And this usually happens outside in another area. So there's a lack of coordination still between these processes. And we do hear from the community that these processes are not working very well for people with a rare disease. So I'll just tell you a little bit what we learned from the project I've spoken to you about a few years ago, a European project that was, amongst other things, implementing a pilot of case management for rare diseases, which was in Romania. And so the project, besides that, there was the opportunity to have actually multi-stakeholder workshops. So there were over 100 people from 24 countries involved in the project, which was quite rich. So beyond the project that was implemented in Romania, we could really have discussions at the European level on what's working, what's not working, what would we want, and how do we make integrated care a reality for people with rare disease. So in regards to the case management pilot, the project defined the case management as the objectives as to improve. So by implementing case management, we wanted to improve the person's or their family knowledge on their disease, their rights and the services, the capacity to manage their own care on what they can in terms of self-management, their communication skills, notably to explain their condition and their care needs. Also, to help them connect more with others with the same condition, to support the coordination between different care providers. Of course, that's one of the high objectives of case management. to raise awareness and understanding of the community, so that was a marginal associated objective, and to prevent avoidable risk situations and optimize the use of services. So this is how it was defined. It was implemented in Romania for 18 months in one region in Romania together with the county, and at the Noro Center that I know some of you will know, the resource center that is in Romania, managed by the Prader-Willi Association and hosting also the National Alliance in Romania. So managed by patient organizations, but it is a center that has therapies, rehabilitation, training, health and social services, and in protocols with the authorities as well, and is a member of ERN Ithaca. So the project was developed there, and with input from in different ways to really shape the pilot the most meaningfully possible. There were 121 people involved in receiving the case management services across ages and various rare diseases, and 2 full-time equivalent case managers employed. Actually, 4 people were employed, but the equivalent to 2 full-time. And they were, I get this question a lot, and so I thought I would mention these. Specifically, these case managers were social workers, a legal advisor, and a special education teacher. But we have also known of case management projects more often, actually, using nurses and being run from the hospital side directly. So we don't promote one specific model of where the case management should happen and who should be the professionals. The most important is how the service is structured and that it functions in your context, in your reality. And each case manager had a maximum of 30 people at the same time. Defined within the project was the role that they would have. So they would be the main point of contact for the person and the family. They would be, of course, providing information, support, and empowering them, being a hub of knowledge, and also being able to really assess the needs with the person and the family, and to help them with holistic and person-centered care planning and coordination. And the experience was evaluated through an experimental design. You will have then, I actually was hiding a lot of the slides to avoid providing too much information, so you will receive them fully and have access to the charts with the results and also the full evaluation report for download. So it was evaluated through experimental design. There were 2 groups. One group was accessing the intervention the first 9 months and the other was not. And then it swapped. The group that was receiving intervention in the first 9 months discontinued for the next 9 months, whereas the others started. So it was possible by measurements before, during, and after the intervention to compare between the groups and within each group how the evolution was going. And different quality of life measurement generic instruments were used for the evaluation, and then some specific instruments tailored to the objectives that were defined for the case management. There was also additional research on upscaling this project. So how do we do case management? What's really important and what's really important for integrated care? Now, what the results that we didn't have last time when I spoke at your conference is that the case management service improved the beneficiary's level of information, something we could expect. It also increased their communication skills and improved coordination of care. And it increased the capacity to manage their own care and decreased the burden of family caregivers. And this was measured using the Zarit care burden instrument specifically. More adding to that is that the improvements, so as I said, one group had an intervention for the first 9 months and then it stopped. So the improvements that they had obtained during the intervention were sustained in the next 9 months because they were measured again, their situation at the end of the 18 months. And so we could see that. And there was less use of emergency hospital services and also less hospitalizations as a side result of this intervention. So you will have, as I said, the charts and the full report to download. But also when we talk about numbers, sometimes it's not very concrete what does this really mean? So what really changed for them? So the evaluators, the team that was evaluating, also collected some actual stories to try to understand what, by having a case manager, their help, the information, knowing about their rights, what changed. And so we saw some people, for example, got access to a personal assistant or to a wheelchair after having spent time looking for that type of support. Some others were able to access employment, rehabilitation, peer support, thanks to the information and the care management that they were able to do with the case manager. And this is quite important, to have this qualitative view of what it means for people and not just measure it quantity wise. So I wanted to say that I'm quite excited because this project ended in 2018, as you've seen, and since then we have been talking about case management as much as we can. And fortunately, there are different countries starting to do it or doing pilots and even evaluating them. And we are very excited that the upcoming joint action to integrate the European reference networks into national healthcare systems is going to contain a piece of work on guidelines for case management. So again, at European level, now involving experts in case management beyond those that were involved in enough care, and also with more recent experiences, to advise also on the integration of these topics in national workshops, so which will be extremely useful, of course, for all the progress on national plans. And we are very fortunate that that work is going to be done precisely with two colleagues, and colleagues specifically from Ireland, so with Professor Eileen Tracy, and also with colleagues from Lithuania. And so it's something coming up, and where we expect and hope to really progress and to really be helpful to different countries, and of course to Ireland in this type of interventions such as case management. I'm just checking my time. So how to achieve integrated care? As I said, I don't have the answer, but I really stick to this. We've tried at PLWRD to say there's so much. We have our position paper on holistic care is 40 something pages, which I'm sure nobody reads. And we try to, it's really interesting, but it's very long. So we're trying to see what are the things that could change the most the situation, and that could be the most transformative. And so we stick really to this I've mentioned before, but also in of care, because I said there was this work about upscaling. So about thinking, how do we do integrated care elsewhere, case management, other ways. And three things were identified as really important: coordination between public bodies, which I thought was worth mentioning here, multidisciplinary teams, and care coordination. And please do note, when we say multidisciplinary teams, it does not just mean inside healthcare. It means bridging the door of the hospitals and of the healthcare services. And the empowerment of people with rare disease and their families. And there were actually extensive recommendations, which I will also provide slides and link after, around how to implement integrated care. And what's interesting about this is that it wasn't just PLWRD. So it wasn't just coming from patients. As I said, 100 people were involved. There was an advisory group of 17 people of national authorities from different countries. So in that sense, it's quite interesting. And I wanted just to mention a few before I conclude, is that, for example, there was one specific area on creating a supportive environment at national level, with several ideas and things that have worked in some countries. And so including interministerial working groups, shared budgets between ministries, so really ensuring that the plans for rare disease and the integrated care for rare disease is not sustained by just one ministry when they are different ministries. Also having top-down and bottom-up approaches, so really making sure that it's quite comprehensive. And including, of course, integrated health and social care in national policies and specifically in national plans, which I know you are planning in any case for the upcoming plan. There were also mentions to financial and structural support to the platforms and networks that really work as collectors of knowledge and good practices. And of course, we do think of the European reference networks and their respective members at national level, but also organizations and patient organizations and other services sometimes act as such platforms. Of course, pilot projects would be great to test some of these issues like case management. My recommendation for that is always, when implementing, really making sure there is an evaluation that is thought of from the beginning, so that there's really more knowledge on the impact. Training of care providers, of course, as we said before, is essential. And also there was this, some countries have this, that coordination between care providers is required already in public tenders, so to obtain funding for certain services. And lastly, there were some mechanisms on integrated care and empowerment mechanisms. And of course, there were recommendations to implement case management, seeing the value that it has, but also, for example, resource centers. And I did not speak too much about that, also for the sake of time. But there are some centers in Europe, for example, Ogrenska Center in Sweden, you might have heard, or Frambu in Norway, or the center where the Enough Care pilot took place. And these centers take a very holistic approach. They're not they're not hospitals. They're not really social services. There's something in between and beyond. And they are quite interesting models to look at, even if they can't be necessarily replicated in every country, and obviously there's a cost to that, but it's quite interesting to learn from their experience in terms of also the support they provide to families and individuals in terms of training, mental health support, managing the condition, and beyond that. So there were different suggestions within Enough Care that are beyond what I was presenting here, that are still valid today, and depending, of course, on what you have implemented and not in Ireland, might be more or less relevant, but still quite to be achieved in many countries across Europe. So I'm happy to provide after further resources on that, of course.
Thank you very much, Raquel. That was very interesting, a lot. I'm a little bit disappointed that you don't have the solution ready for us. I thought that you'd come with an answer and we could all just, do another couple of weeks of work and then we can all go into retirement, but sadly not. I would like to invite up my panelists here. I have Lorraine McGlinchey, coming to us as a family member with rare heart conditions, and Lorraine is around somewhere, I'm not sure where she is. She's coming, there, I see the arm up in the air. Lorraine is also a European, one of the EPAGs, the Irish EPAGs in Gardhart, ER in Gardhart, and is an adult nurse lecturer. Yep, please, thank you very much. David Keegan, a consultant ophthalmologist at the Mater Hospital, and not to denigrate any other healthcare providers or clinicians in the room, David, I always find, has a very interesting angle on his challenges of making sure that his patients receive the kind of care that they need. He has given a lot of thought to it and is always very enlightening and inspiring, I believe. Alison Moore, who is the I think the rare disease clinical lead, probably actually the children's rare disease clinical lead. It is adult, okay, sorry. Adult rare disease clinical lead coming from Northern Ireland through the Belfast Trust. And Ciara Martin. Ciara is still here, yes. HSE National Clinical Advisor and Group Lead for Children and Young People with the Office of the Chief Clinical Officer, so in Colm Henry's office. So I'm not even sure where to start. What I will say is that the reason that I'm here, sitting at this table as the chair of this group, is it was extraordinarily difficult to find anybody who could really say, you know what, yeah, I'm happy to speak about this topic. And I had to hoodwink and browbeat some of the people in this room. And I think it's a reflection of, we all know that something needs to happen, but none of us are quite there yet. None of us are quite at that stage saying, yeah, I'm going to lead out on this, I'm going to make this happen. And, I would hope that over the next 3 months or 6 months, we can really have some really good conversations on what needs to happen and how we can do it. Back to Cecily's implementation plan. What are the moving parts? Who are the people that need to be involved? And that this time next year, if we were in the same position, that there'd be 10 people saying, yeah, I'm here, I'm ready to give it a go, I'm ready to do it. I'm going to start with my first question for Lorraine. What is integrated care from somebody who's living the experience? What would you like to see?
I suppose, I can see it from a lot of points of view. I can see it from a family perspective. We have a condition in our family called CPVT, which I know Alison will know about. It's a catecholaminergic polymorphic ventricular tachycardia.
For those that want to know.
Thank you. Not the cardiologist in the room, but so it's difficult to say, but it's also rare. And unfortunately, CPVT, which is the short version for it, causes sudden adult death syndrome. And as a family, we've lost 7 people to CPVT or to SADS. So integrated care to me means not having a stopgap from here, from A to B. I was asked this question this morning because I was at another conference. Who do I turn to? For somebody who's getting a new diagnosis, or they just, as was said earlier, a bombshell of, you have a diagnosis of this disease that you have no idea what it is. Sometimes when you're getting the diagnosis, you don't even hear what's been said. You've heard this word, that's it. Everything else goes over the top of your head. Who do I contact? Who do I go to? Who do I even go to find out the contact? Who's going to support me? Who's going to look after me? Who's going to look after my family? These are all the questions that we need to be able to have on the ground for families like ours that absolutely have no idea where to turn to next. They just find this diagnosis sitting right in front of them and they have no idea where to turn. So I am also, should I say it, I'm an orthopaedic nurse, so why should an orthopaedic nurse be very much into cardiology? But as you can see, I have a thing on both. So I can see from a nursing point of view, I will, refer patients out for, for follow-up in the community or whatever. We need to have all those links in place to be able to know who to put that person in contact with, and that they will be looked after as a family, as opposed to one person, adult or children. I know that might be a very long-winded way of saying it, but not only that, then it's your support groups. Say like for an instance in ours is like of CRY Ireland, the Irish Heart Foundation, or the fact that I'm the representative in Ireland now for these rare arrhythmias. So I can link back now into Europe to be able to get the care and the support, both from the clinicians but also from the patients and the families. So we can link now out through Europe as well if we need to have that as well.
Mm-hmm. David, I see you busy making notes there. If I pose the same question to you, what is integrated care? And it's a question that we actually have discussed with Derek previously, and where the Rare Disease Patient Forum as part of the strategy. It is the first question we need to ask people. What does it look? What does it feel like? What does it look like? What are we actually trying to do here?
I think Lorraine's brought us through is a lot of those challenges to delivering integrated care. So with integrated care, I always preface this as just an ophthalmologist. So if you want a real doctor, don't ask for an ophthalmologist. But with regard to integrated care, it is exactly, I think the talk from Raquel was just really summed it up. I found myself snapping slides. I'm supposed to be sitting on an expert panel here. I sit in these expert groups. But actually a lot of what Raquel distilled into is that integrated care. It's that because and it's one of the challenges we've had in ophthalmology, and Avra will know this, to framing a national vision strategy, which we did many years ago, because the pathway that came out that time was all around acute hospital medicine. And Raquel alluded to it in her talk. There was nothing about that pre-hospital piece where they might go to an optometrist or talk to a friend, talk to the GP, and there was nothing on the other end about post-acute care, rehabilitation, low vision assistance, when you've maybe done all you can, or there was nothing to do in the acute hospital setting. And that then funnels right back to the lived experience of patients, and through my own involvement, well, from knowing Avril for years, but through Fighting Blindness and now Vision Ireland patients, that shocking lived experience of their first encounter with a healthcare professional never leaves a patient, never leaves. If I'd learned one thing as a clinician being involved in it, is that piece. So there's integrated care failing right then and there, is that patient's first memory is that interaction of somebody who doesn't know what they're talking about, doesn't have the honesty to admit they don't know what they talk about, doesn't know the pathway maybe to put the patient on to help assess that, or all the other pieces around it. But we can't know everything. So, sorry, I've got to come back and answer your question directly. Integrated care is all the bits that Raquel talked about in there, in that talk.
Yeah.
Right from the start, the awareness of an issue, whatever that is. I mean, maybe arrhythmias, it's just that awareness of that flutter. Doesn't have to be the sudden event, but actually generally you'll find that there's something's been happening prior to that. And then knowing where to go. So that's what I was jotting down here.
Yeah.
It's that it's an awareness program. It's a screening program. Then you got to decide your population. Are you going to wait for this opportunistic to show up? Then it's into your care program or prophylaxis program. But then you need your support mechanism in place. Then there's a post-treatment program. Raquel talking about the psychological aspects. Sorry, I'm talking too much, but it is all those bits, and we have support.
I think actually one of the things that you just said there about that first interaction with your clinician, and I would suspect, Raquel, it's a similar reaction or a similar approach in Europe as we have here in Ireland, that our clinicians are all-knowing and on a pedestal, and if you're now falling off that pedestal in our world, and therefore this is devastating, this is worse than I thought it could possibly be, because I thought you were going to answer all of my questions. And I wonder, do we all need to kind of like, actually, I think back to Mary Carney's earlier conversation around there's 6,000 plus rare diseases. We've got to be able to acknowledge they're not going to know everything about everybody and about all of these conditions to the level of detail. And so it's trying to make sure that we as a society recognise we're not infallible. Our clinicians aren't all-knowing about everything, and therefore we have to give a little bit of that, and maybe then that experience isn't as devastating as it could be, or as some people, as it is for some people, I should say. Alison, I know that you're, I think, relatively recently in position in the north, and I'm sure there's about 1 billion moving parts. And now that you have a Minister for Health in situ, there's 1,000,001,000, and that one is the most important one. When I discussed with you again, please do something for me. You were talking about, we're in the job of embarking on care pathways, and that's a piece of a component of it. How's it going? Are you having? I know that we've done work here in the south on care pathways, and it's been an eye-opening experience, I think, in terms of the patients, what the patients are saying about what they're looking for. Are you getting the big challenge we have here? Commissioning. Are you getting commissioning? Are you that far along? What's going on with care pathways as a component of the integrated care model, I guess?
Yeah. So I guess what we've started with are services that are currently in place to varying degrees. Can I just say I'm really impressed with how quickly you managed to put my name in the programme, because I know when I agreed to do this. It's impressive. Get you to come and sort my care pathways. So as part of the work in Northern Ireland, what we're trying to do is learn from services that are in various stages of development already, but those care pathways are not documented clearly to be shared with our colleagues in primary care, to be really visible to patients, to know what the pathway is that they have to follow. I would add on to that first patient interaction, which is terrifying. I think once they've been given the diagnosis, it's actually, going back to what the city said this morning, it's nearly more terrifying that they've come back for their 10th visit and they still have to explain what the disease might be. And I think that's a component of, we have to respect that patients are experts in their rare diseases and they have to be allowed to tell us about their rare disease. And that it's not an education piece to teach a doctor about every rare disease, because that's impossible. But we probably, as part of our education, need to teach our trainees that actually our patients can teach us, and it's okay to say, I don't know the answer, but I'm going to go and find someone who does. And so the work that we're doing at the minute is in a group of six adult rare disease groups, a slightly different but overlapping group in paediatrics. And we are working through creating complete service specifications and documenting complete service specifications as to what the service should look like on paper to deliver the whole care of that condition. Within that, then, there are the pathways of how primary care will refer in, how patients can refer themselves in, and the transition piece, because we know that collectively, as doctors, we don't do transition brilliantly well. We all try very hard, but actually you go from that bosom of love and bubble in paediatric care to the big, horrible world of adult medicine, where there's just not the capacity to treat patients the same way. And so it's trying to transition that. And so one of those things that we've done, certainly in my... So I'm the adult rare disease, but by trade I'm a cardiologist. So I'm a genetic cardiologist. I look after inherited cardiac conditions. And one of the things that we've done is that I try to meet the children and their families at a family clinic, because parents and children are affected with the same condition, so you come to the one clinic. And then you transition over to adult care, and we've introduced this thing now where you get a letter which will say, you're now my patient. If you have a problem before you meet me, it's okay to still phone me. I'm your doctor. So you know, so families know who they're looking after. And we're trying to get these overarching principles of transition embedded into all of our care pathways. We've published a paper on this sort of the higher level themes of transition, and then they're all going to be embedded within the care pathways that are being written at this minute in time. And alongside that then, after discussion with the gentleman, I can't see him now, I talked to him earlier about making sure we have access for patients to get information, links to the relative charitable agencies for their disease, and trying to link up all of that as a whole piece. We're starting with services that are reasonably well established, simply because we've got to walk before we can run, and we have our commissioners on board with us, and we're getting those services that are already in place well documented, learning what works well, what doesn't work well, and then we will branch out in the coming years to other services that are not just quite so far down that pathway.
Okay. Thank you.
Does that make sense?
Yeah, no, it does. It does. It's a journey. It's a long journey, and it's not going to happen overnight.
This time next year, we'll have loads of care.
Ciara, we've had an integrated care programme in the HSE for a number of years at this stage, and when I look at it, and I look enviously at the HSE website, and I kind of go, wow, we have clinics around the country for different common rare conditions. We have the expertise available in communities around the country. And I don't expect that to happen for all rare diseases. It's just not practical. We're too small a country. But I wonder, in all of the work that has happened previously or to date in those areas, there must be learnings that we could say, you know what, yeah, we can, there's an expert centre located in Galway, and we know that all of these people can travel there, or there's some people that can't travel and we need to do something. There must be learnings that we can do around what has happened already, that we could actually say, it's not as difficult, because we keep on talking about it's complex, it's hard. It's kind of like, as I opened earlier on, it's kind of like, it's the human condition. It's actually just people talking to one another and working out. And every single individual will be different, and it's not because of their clinical diagnosis or their epigenetics or their phenotypes or their what all of those other words. It's actually just, I have access to a car, I have a child to pick up, I have, my bank manager is on my back. Those are actually what make us all individuals as well. So I don't know, is there stuff that you could say, yeah, we can bring stuff when we get the team in place, and that'll probably be part of what we're looking for with our implementation plan, is to get a team in place to be able to do that. But are there quick wins, do you think, for us in this area?
Well, now, to speak for the whole HSE and say there's quick wins, that's tricky. I think what you're referring to is really, I think it's really important. So I think with the HSE and integrated care, it's like everybody else, it's on a journey, and starting with, as you said, the quicker wins of the bigger chronic diseases and moving care out into the community has been really important, and feedback from that has been really good. And it was that we have to show it can be done. We have to show it can be done, that you can work with community people who work through hospitals, through communities, and be effective and provide care for patients and families. And as well as that, we're very connected with the kind of international approaches to integrated care. And one of the big learnings for me, I'm a doctor background, pediatrician, was that realization that actually a patient's care, less than 1% is provided by health professionals. There's 3 of us sitting up here, and yet it is the parents, it's the carers who provide 70% and then the NGOs and community primary care. And really that's where we need to be working. And to do that, what we need to do is break down a lot of the silos that have grown up with an organisation within, even, like the HSE and the way it's funded. And I think some of the changes that we're undergoing at the moment are going to be really beneficial for us. The fact that we're breaking down into regional units. We've broken down the barriers now between acute and community, so there's one person, or one group looking after everybody. And we're also learning from that kind of our public health colleagues. They're on board with so much of what we're doing, and it's all of that population health needs approach. It's slow, but I can see, even I'm in post with Dermot and Abby about 2 years, and I can see that there is a change. And like that, it has to break down that barrier to say it shouldn't matter, if you come with one rare disease, to say, the only place you can be looked after is, and I'm a paediatrician, is in one clinic in CHI, whereas actually what you need is a speech and language therapist who might be closer to home, who can certainly link with your specialist, but provide the care you need. So I think it's a long-winded way of saying it's a journey. It's started, and I can see a change that's there, and I would hope that it has to benefit everybody. And we do need to be breaking down all of those barriers.
And can I ask you, Cecily spoke about, when she was speaking about the interest levels that have come to her around the rare disease strategies. Oh my Lord, there's people knocking on her door. Are you getting that from your colleagues? Is there an interest in there? It's kind of like, these are the difficult but interesting cases. These are the ones, the challenging ones. Or is there a kind of like, oh no, run for cover. Let's hide away from this. It's more out of interest. How do we make this be? Because I do feel that, the generations that are coming through med schools and through nursing, they see opportunities. I look at all of the industry in the room. This is, what everybody is interested in. We're all talking about personalised medicine. We're not there yet, but it will happen at some stage. And I guess if Elon Musk had his way, it'd be happening tomorrow or the next day. But, it will happen. And is that seen as being a real opportunity that excites people? Or is it seen as being a kind of like, oh, let me out of here. I can't. It's too much.
I think certainly working with the Chief Clinical Officer and in clinical design and innovation and integrated care, any opportunity we have to raise patient care awareness, and the work that you're all doing in the room to, you know, whether it's with individual rare diseases or as Rare Disease Ireland, of course it's welcome. You know, we need advocates, we need people who are in touch with our politicians and our departments of health, and it is really a matter of everybody will rise together, hopefully. So I certainly, in the area I'm in, I don't see it as, you know, a burden when someone rings you about something unusual.
No, I wouldn't even say it's a burden. Just, you know, I guess historically the politicians have maybe gone running because they just see dollar signs or euro signs when you say complex, and I think it's not the right mindset to have. That actually it shouldn't be. It's, you know.
Exactly.
Anyway, I won't ask you to speak for everybody.
Yeah, no, and I think you mentioned earlier when you were saying, you know, it's getting to the bank, getting to the school, getting to the parent-teacher meetings, you know, no matter what you have, they're all part of your life, and it came through in a lot of the talks today. So, you know, what the genetic component of your disease is, there's no doubt that we all need health and social care, and we need community care, and we need education involved, and we need to be getting better from the ground up. And also valuing I'm a paediatrician and I work in child health, and it's valuing every stage of childhood, and, you know, we're doing a lot of work on that transition to really value our young people as young adults, not as people who are going to be older adults, or, you know, to really have every stage mapped along the way. So it's all that kind of central patient as centre, but recognising that patient has to grow on a life journey too.
Okay. David, you.
Vicky, you should have warned here there was an opportunist on the panel. I don't really want to call you out in front of everybody in the room. We've got 3 pathways that are looking for funding around rare syndromic eye diseases. So I'll drop into your office next week.
You can. I have no funding, but I'm happy to talk anyway.
I was actually going to come back to you, David, anyway. I guess stepping out a little bit, you know, we need to acknowledge we're a small country, population 5 million. We're not going to have expertise in everything. The ERNs that Raquel speaks to, that we've all spoken to, that have been in existence since 2017, and I know you've been involved in and are now leading one of them in the country. Are they all they're cracked up to be? Notwithstanding, I know the need to have better data and, you know, supports around it in Ireland. But, you know, what you see happening in Europe, is it really going to be pretty good, or is it just not going to really?
It's a really good question, and I think it's a really good question. Remember, the Irish participation in the ERNs was hampered by our political circumstances in 2017-18, so just one ERN got launched. So the other 16 the Minister talked about are only in about 18 months. We're not long in that system. So I'll answer, I heard about at a European level, I'll come back to that second. At an Irish level, there's still more we need to do to support the ERNs. I think it'd be remiss of me to sit on this panel and not speak on behalf of all the ERN leads in this country, which is 18. There's fundamental administrative data management support that's required to meet the legal requirements that we're obliged to be members of the European structures, the ERN. So that has to be said. Eileen Tracy in the Rare Disease Office has done a huge amount to try and advocate for that funding. It hasn't come through. And I know it shouldn't always boil down to money, but some things just, and it's a modest ask for that. That's from the Irish perspective. That leverages us up to adequately meet our audit needs. Irish members are very active members of the ERNs, and that's evidenced across them. And I know Avril would have familiarity across all the ERNs, and Eileen as well. We're very active in the I one. Now, going back to your core question, will the ERNs deliver what they purported to deliver? We're definitely in a better position now than we would have been without them. I think people came into them with mixed expectations around achieving sort of research goals versus clinical goals, and I think some people drifted a little bit away when it was very much as a European collaborative clinical project. It should really be seen as replacing the treatment abroad for diagnosis, diagnostics, and to avoid that. I would have to say probably hasn't caught fire, and some ARNs will be better than others around that. The establishment of the registries, and really only one of the ERNs has a really good going European registry at the moment. We're fortunate we've been allocated as the centre for the I1 here in Ireland. So while that's nice for the group, but I think it starts to bring some of that expertise in and a little bit of that funding. And then to realise the full dream of the ERN is that access to that sort of high level, same standard care across Europe, be it towards genetic testing, genetic counsellors, resolution of very difficult decisions, that's a little bit away. And I think all the groups are looking to do audits of where Europe sits, where all the countries sit as regards different services. We just completed one now for, say, low vision rehabilitation support services across Europe. So the difference is huge between Ireland and France and the UK, but then you go to Bulgaria and Romania, and it's different. So there's some basic building blocks we need to put in place. If let flourish, there's a lot of bureaucracy. Like, if let flourish, they'll get there, but I'd still say that I can't think of a better phrase. I mean, Avril's very involved in it as well, and many others in the room, probably yet to catch fire. That'd be a fair phrase. But
Lorraine?
Embers.
Yeah, I would say, because from my point of view, the Irish, the cardiac arrhythmias end up at the Guard Heart. I'm only in the ERN now as an EPAG for a year, and that's the first Irish EPAG that has been for, as far as I'm aware, for the Guard Heart. Yeah. So we are only sort of getting up to speed as well in that area. So, but I can see that it will do a lot of good, and now that we actually have a board meeting now in Paris next month, so I'll be going to that and hopefully getting, to be able to put more input, but get more back as well, that I can bring the information back with me to see what we can do here in Ireland for the patients and the families as well, for their care going forward.
Raquel, I'm conscious that I still have you sitting there and you're diligently paying attention. I am wondering, Raquel, I guess not to put you on the spot, Avril won't hold it against you. Where would you say we start? I mean, like, what is the first step? I mean, you've heard the conversations here that, there's bits happening in areas where there's a bit of expertise and stuff. But, I guess I've looked at a study over in the UK, the Concord study. I don't know if you're familiar with it. And, are they slicing and dicing it in a manageable way, do you think? Or are they missing the big picture? Or, I guess I'm at a bit of a loss as to who's going to be. Maybe, Raquel, you want to relocate here for a year and you can help us to get everything off the ground. It is a green country. What do you think?
Well, certainly. I should at least make it to one of the conferences in person, second time online. Well, I think it's very interesting, all that you're doing and that you're mentioning, and I fully understand and support the approach of starting with what's already there and going step by step. It's obviously a very big mission. So I don't have a place to start, but I have a place to not finish at. So that's really counterintuitive to your question. But for me, what I see is that there's always a risk that we overly focus on the conditions. And so on how the pathways work in terms of healthcare, and then that we miss to go beyond that. And obviously that's very challenging. We can't know everything. And so it's really more understanding what kind of mechanisms or roles can there be to help with those transitions and those links, rather than thinking that there's a solution where all that will be sorted in 1 minute. That's not going to happen. But it's just thinking that for example, when we looked at case management in enough care, it wasn't specifically for a rare disease or a group of rare diseases. It was across rare diseases, which sometimes is not an approach we might think of, more medically thinking. And so the case managers were trained in a way that they had skills on communication and where to find things, but they didn't know about every rare disease. They knew where to find the doctors, where they existed. They knew where to find the resources, who to reach out to in order to make links, but they weren't experts on the medical conditions, for example. And so this is one of the examples, because if we think of implementing, for example, case management, we will think this has a cost. We need to employ people, or we need to take people's times, already people who are employed, allocate some of their time, etc. And then if we do it by specialized units within healthcare, then it becomes, and I think it's also looking at the approaches where they are sort of process approaches that might work across groups of people with rare disease who might be supported within the same hospital, for example, of course, or in different hospitals. But thinking of solutions that might be serving a wider population and not necessarily try to make everyone an expert on the conditions. So that's one thing. And the other thing is thinking of the people as individuals, which I know is extremely tricky, because we want to have the pathways, we want to have the links happen within healthcare and beyond. But then we really must not forget to ask how people actually want to live and what their choices are, and to support them in those choices, and not the standardized pathways that we had to develop to make things work. And it's good that they are there, but to make sure that people actually really have a voice in saying what they need.
Yeah, I hear you. I'm going to open the floor to one or two questions. If anybody, I see Alan Finglas has his hand up here.
Just a couple of thoughts in terms of where we could start. Some people might be familiar with an assessment of needs program for children that have developmental delays, and it's a reasonably good system where they assess the needs. And they sit down with the family, they talk about, and the patient is assessed by experts in those need areas. And if we had something like this to try and, as a starting point to try and provide integrated health and social care, I think that will be important. And obviously that will need resources to be able to do that. But I think if you don't sit down and listen to the patient, family, you're not going to do anything. And we're kind of in Ireland trying to go from zero to somewhere. And so that would be my first thing. And then the second thing, which is kind of woven in with that, if a particular condition, if there was a care pathway or care guidelines, I prefer to refer them to as, for that disease, that the family and the healthcare team would sit down at different intervals and review those guidelines. Because if my son was diagnosed 9 years ago and I sit down and I read the guidelines then I read them after at even 1 year, 2 year intervals, you're going to see different things on that. And now you're trying to provide care based on evidence and not care based on symptoms. Mm-hmm. So they would be my two wishes to go from zero to somewhere in this regard. Thank you.
Yeah. Thank you, Alan. Thank you. It's a good starting point. It's an under-resourced one, I suspect. It's a good one.
Hi, my name is Miriam Martin. I've come down from the north. Okay, so I'd like to welcome everybody here, the new people. And I would like to say I'm from a neurological charity, Sringo Maile Arna Carey Association. I like to hear, I've heard a lot of good stuff here today. Congratulations to everybody who's put it together. I like what Alison had to say about the transitioning for children to adults and about being told, you're now my patient. Well, I think there's also a gap when people transition in their senior years, and it's something that people are not even aware it's going to happen. So many people are managed in the community, and they have a team looking after them, and then coming up to their 65th birthday, they're told, you're no longer going to be my patient. That's very tough for somebody who's built a relationship and has received good care. And I think it's something that should be planned for and dealt with delicately, rather than somebody it being handed down all of a sudden and being told, you're no longer going to be my patient, you're turning 65. So it's something to consider, and it's something that, as I say, we have a lot of adult members in our charity, definitely, willing, say, we're members of the Rare Disease Partnership here in Northern Ireland, or up in Northern Ireland, so something where we'd be willing to talk to any of you about. Thank you.
Thank you very much.
Can I make a comment?
Yeah, Alison, if you want to, and Dara, there's a question up at the very front. But Alison, if Alison wants to respond.
I'll be really brief. So there's a development. I mean, I guess the thing about rare diseases are that very often a patient gets looked after from a paediatric age group all the way through to adulthood. And so rare disease services balloon, and we can't follow everyone in the same way forever because we are restricted by capacity. And so it's trying to come up with innovative ways to stay in touch with our populations. And I think there's something that we're looking at now where patients don't necessarily need us all the time if they've got a diagnosis and an established management plan and established who their consultant is or who their team is. So we're looking at this new strategy for modernising outpatient follow-up with a thing called PIFU. So it's patient-initiated follow-up. Mm-hmm. So you can remain someone's patient, but you don't need to keep coming back to the clinic. But you have someone that you can call if you get into problems. Because actually sometimes people just need to know, I have someone that I can contact if I have an issue, but they may never have that issue. And for a lot of the inherited heart diseases, that is what we will do going forward. We will try to say, look, you are a patient, but you don't need to come to us, but you call me if you have a problem.
Yeah, slightly different approach.
The GP is often the person who's more involved, and as you say, clinicians are as involved. But I think it's an important thing to prepare and that people are more aware of it, and that little piece of paper or an email or a text, being given the name of the contact in advance, and maybe even a very brief meeting, the handover from one physio, social worker or whatever to the other.
Okay. Do you want to, Bruno, I think it is, yeah?
Yeah, it was just, I think I disagree with everybody, but basically I do not agree with the community approach. The expertise is in the hospital. I went to speech and language in the hospital because you have to go to them first of all, and then they send you to the community. They had other patients with my condition, so they were able to tell me stuff. I've gone to 5 different speech and language therapists in the community. None of them have met anyone with my condition. I've also had issues when it comes to physio. In the community, you have physiotherapists. You have neurological physiotherapists. They are in the hospital. You need to be in the hospital. I also have the issue that when you are sent out to the community for, say, what's the word? Yes, psychology or whatever. The issue is a lot of neurological conditions are genetic, so family members both have them. You can't be with the same psychologist. So I have no psychologist because my sister has one. So what do you do in that case when the hospital won't take you on their system, but yet they're sending you to the community? The community won't take you on theirs.
Yeah, and I think it's not the very example of, it's the individuals. It'll have to be accommodate every individual's needs. There is no one size fits all for this. We'll try and, I guess, get systems that'll work for lots of people, but we have to recognise there are still individuals. David, you wanted to add something there?
Just make a comment on that, and thank you very much for sharing, because we can't get enough of those stories back about the feedback, about the lived experience, but just try and give some, I'm going to try and give a little bit of comfort with what I'm about to say, and I hope it does come across correctly. We can be criticised the health service over many, many things, but there's a fundamental restructure of health service. No, I'm agreeing with you. So,
but I'm not criticizing.
no, I know you.
In the sense that the expertise is in the hospital. It just won't keep me in the hospital system to get it.
No,
It's there.
I agree with that. I was going down a slightly different route about the restructure in healthcare. And one of the plans is actually bring some of the expertise out of the hospitals and into the community. It's the flip way around. So yes, it's to try and bring that expertise closer to people in the community that need it. Mm-hmm. So it's not the community facility it's the expertise isn't sitting in that building. So what we would try and do through some of these pathways is that to deliver that by the right expert. So somebody who has seen patient with your condition or with other, or like that neurological physiotherapy, but try and deliver it out. Or am I missing the point there? Or there's a comfort in the centre.
I'm trying to get across that we're rare conditions, so you're not going to have enough people with the expertise knowing other people with this condition in every community.
No, I appreciate what I'm saying is we move the experts out of the hospital. So if we've got an expert in Beaumont in neuro physiotherapy, but actually one day a week they're in Cavan or Monaghan delivering neurophysiotherapy to a community in there that needs it. So the patients that require that specialist care don't have to get on a bus from Cavan or Monaghan down to Beaumont. We bring the resource from Beaumont out to Cavan. That's what I'm trying to get to. But the frustration, I do realise over the years, the frustration is talking strategy is much easier than delivering on the strategy. So I fully put that qualifier in. I've had my own fingers burned for things, but it's
okay.
important it's important to have that feedback back.
Yeah. Thank you very much, Brona, for sharing, and David. And I'm going to, in the interest of time, because I have now my religious half hour behind, but I'm going to blame that on somebody else. Raquel, thank you very much for taking the time to zoom in with us. Really, I think there's a lot of insight, and I think we'll be back to you with lots of questions and things like that over the coming weeks, particularly as we're embarking on writing up strategies and implementation plans. And thank you very much to my panelists. I know I browbeat you, and next year you'll be dancing up here saying, "Yay!" I know what to expect, but I really do appreciate it. I know it's not easy, and sometimes it's a little bit daunting to be up here, particularly with me, who just keeps going and going and going. But there's more tea and coffee outside. We're going to cut this break super short because I really do want to make sure that we have a good chat with Emer Cook from the European Medicines Agency. Right, thank you very much.